WDL means within defined limits, but what does it mean when you're choosing to chart WDL within your assessments? If you're unsure what WDL means for a given body system, click on the blue text for the body system in question to be taken to the reference text for a description. It's helpful to note that you can click on any blue text in iView to be taken to reference text for a description. If your patient does not meet all the criteria stated in that reference, do not choose WDL as part of that assessment. Fall risk screen needs to be completed at least Q shift. The frequency of fall risk interventions is determined by the patient's risk level. If a patient is high risk, we need to document the fall prevention intervention Q2 hours. For moderate or low risk, BID. Again, remember the blue reference text links. These will often have more detailed information about the fall risk fields. The fall intervention task has now moved from the Schedule tab to the PRN Continuous tab. Because of this, it will not put the documentation time into nice 2-hour increments. You will need to remember to document your fall intervention Q2 hours for high fall risk patients. Some other options are, number one, you can still use the continuous task and just insert your own time slots. Number two, you can just change your iView time slots to Q2 hour intervals and document your fall interventions. Now let's talk about stroke documentation. A baseline assessment is needed for patients who are admitted or develop ischemic or hemorrhagic stroke. These assessments can be found in multiple areas under iView Systems Assessment. They are neurological, cranial nerves assessment, musculoskeletal, stroke, NIH stroke, and swallow screen RN. Minimal requirements under the systems assessment include level of consciousness, orientation, speech, cranial nerves 2 to 7 and cranial nerve 10, which is your swallow screen, as well as strength, sensation, and gait if appropriate. The NIHSS needs to be completed within 15 minutes of arrival to the unit. It needs to be performed at the start of each shift and with any changes in neurological status. Report any worsening changes to the provider. The swallow screen must be documented in the EMR prior to the patient receiving anything by mouth. It is best to add this to your baseline neuro assessments. Patients who fail the swallow screen must remain NPO until the speech pathologist completes a formal swallow eval. It is the responsibility of the RN to order the aspiration risk standing order set. If performing a swallow screen is contraindicated due to patient condition or other factors, a failed swallow screen should be charted to trigger an NPO order and a speech consult. You can manually fail a patient by entering it into the swallow screen assessment outcome box. Some nurses have added in the Focus Assessment ED band to their iView, as this band has all the documentation needed in a single section. If you do want to add it, you can go to iView. On the very top, you want to go to View, Layout, and Navigator bands, and pull over the band called ED Complaint-Based Assessment. If you need any assistance, please give us a call in CIS. For patients who have received thrombolytics for stroke, be sure to document a full neuro assessment along with vitals every 15 minutes for the first 2 hours, followed by every 30 minutes for the next 6 hours, then every hour for the last 16 hours. This equates to a full 24 hours of frequent assessments post-thrombolytic administration. It's important that you also clearly communicate the timing of these assessments during nursing handoff. While documenting your stroke assessment, refrain from using the no change from previous assessment option. If you were unable to complete vital signs or stroke assessment at the expected time, please add a clinical note under the time that it was due to explain the reasoning. Be careful to do the vital signs for the entire allotted time. For example, your first Q15-minute vital sign starts at 9:15, but you start your Q30 vital signs at 11 instead of 11:15. Remember to document your stroke education, which can be found under the topic of Quality Core Measure Education. Patients and families should be educated on stroke and personalized risk factors for stroke Q-shift. Ensure that your education is customized to the patient's risk factors. If the patient is not able to receive education due to acuity of illness, remember to chart that as a barrier to learning. Here is an example of the Med-Surg and telemetry stroke documentation checklist. The stroke documentation checklist and self-audit tool is required to be completed on all patients who are admitted for suspected or confirmed acute ischemic or hemorrhagic stroke. This tool was developed and implemented after a TJC finding of inadequate documentation of neural assessments and vital signs for stroke patients. Our goal is to ensure we are compliant with 100% of stroke documentation 100% of the time. This tool should be filled out Q-shift by each RN caring for the patient. It is both a checklist and a self-audit tool for your own stroke documentation. Here is an example of the ICU stroke documentation checklist and audit tool. The purpose of these tools are threefold. 1. To ensure elements of stroke care and stroke documentation are completed at required intervals. 2. Ensure RNs are reviewing their documentation and correcting any areas of forgotten documentation before end of shift. 3. Reflect on missing documentation and self-identify opportunities for improvement. The tool for both Med-Surg telemetry and ICU should be utilized and filled out while the patient is in the acute phase of stroke, days 0 to 7. Now let's talk about pain assessment. On initial assessment, remember to document the patient's acceptable pain level. If the patient has any pain, an in-depth assessment is needed. Remember to select the pain scale used to trigger that assessment. When administering an opioid, a baseline pain assessment is needed, which include pain intensity level, pain level, and the POS, which is the Pacira Opioid-Induced Sedation Scale. Pain reassessment documentation. Remember the acceptable pain level. It will carry over if it was documented previously. Remember to complete all the required fields. Clicking yes on the patient refused vital signs section will remove the required fields for vital signs. For PCA documentation, if you would like a task for your PCA documentation, you can enter in the order called PCA Assessment Q4 Hours. This will create a task for you Q4 Hours that will take you directly to the PCA field in iView. This can be ordered as a scope of practice order. Let's go over some PCA highlights. 1, under PCA medications, enter not only the PCA medication but also the concentration. For example, fentanyl 10 micrograms per ml. 2, PCA continuous dose unit of measure. They recently added a new selection of ml per hour for use in epidurals. 3, a witness signature is needed either through the MAR, for example, on initiation or change of the syringe, or in iView under PCA comments. This witness signature is needed at the time of initiation, any bolus or loading doses, rate or setting changes, syringe change, change of shift, as well as Q4 hour setting review. Let's do a quick review on how to document a witness signature. The witness will go in with their own login and document that they witnessed the PCA under the field PCA comments. Now let's talk about the CSSRS suicide risk patients. If a patient is at high or moderate risk for suicide, a patient safety attendant or PSA needs to document 15-minute checks. If the patient is at high risk, this will need to be done at the bedside. If the patient is at moderate risk, the PSA can be in line of sight. Both high and moderate risk will need a paper care plan done. A patient safety plan needs to be completed upon discharge. A lifetime assessment needs to be completed by the social worker. The turquoise wristband is for high-risk patients, and the band stays on until a lifetime assessment is completed and the patient screens either as a low or no risk. The provider will need to document on the 6 risk factors for suicide when deciding to discontinue the PSA. PSA documentation needs to start from the time the patient is deemed a high risk until we get an order from the provider to discontinue the PSA. Document under Communication Physician the time the physician gives the okay to remove or discontinue the PSA. The care plan is a paper form. Make sure all the fields on the care plan are completed, including the initials. Also make sure your signature has a date and time. On the flow sheet, make sure all the documentation at the top is completed on each page of the form. It needs to be done every 6 hours. Document on the flow sheet when the PSA is discontinued. Finally, remember to complete the patient safety plan upon discharge. The sitter monitoring form, on the other hand, is for non-suicide risk patients. Remember to fill out all the fields on each page of the sitter monitoring form and make sure that the start time matches the time on the flow sheet. The next topic is home medication list. Open your home med list by clicking on the Meds History button under the Adult Intake. You will use the Meds History button or External RX History button to review and add or remove any medications from the home med list. The External RX History button gives you the option to import the last filled medication list and individually add them to that list to the home medication list to document on the patient's history. Keep in mind that the External RX History list may not necessarily have all the medications that the patient is currently taking. Manually adding the medications to the home med list can be done by using the Add button within the Document Medication by History window. If the patient is unsure of the exact dose of the medication that they are on, you can still add the medication name to the home med list. You may already see medications that were previously populated within the home med list. Please review the list to make sure that it is current. Medications with the pill bottle icon next to them means that they have been populated by a medication prescribed through Castle. If the patient is no longer taking the medication listed, right-click and complete to remove it from the list. An example of this would be an antibiotic that the patient is no longer taking. Right-click also allows you to update the compliance on the medication. If that patient is not compliant with the home med, please add a comment to describe why. Now let's talk about social history. Default filters on our social history page shows all active documentation. So any documentation on the social history page will trigger consults to our dietitians, case managers, social work, and chaplains. It is important to keep the social history up to date and remove any old documentation. Now let's talk about some basic steps in documenting social history. Number 1, modify previous documentation by double-clicking on the assessment. Number 2, if you are unable to modify, remove that assessment and create a new one. Number 3, remove any other older documentation by doing a right-click and selecting Remove. If nothing changed and everything is the same, go ahead and click Mark as Reviewed. You will still be able to see these discontinued assessments by changing your drop-down filter to All. Now let's talk about medications on discharge. Remember to give education on any new medications. It is good to include the handout for that new medication as part of the discharge instructions. Finally, I just want to talk about eCoach. eCoach is a great tool to use for reference. You can access eCoach through the top of your toolbar in PowerChart or on the Connect page under My Toolbox. Choose the nursing icon to see all related job aids on nursing charting and processes.